Uh, Good afternoon, everybody. It gives me great pleasure to introduce eminent Dr. B.D. Goswami. Dr. B.D. Goswami, as you are known, is a well-known gastroenterologist and hepatologist. Doctor, doctor, doctor is also the HOD of the was the ex-HOD of Guwahati Medical College, and doctor has been trained at USA at University of Virginia. Dr. B.D. Goswami was also elected as the top 5 gastroenterologists in India by the American College of Gastroenterologists. Dr. Goswami has, to his credit, more than 45 national and international publications. I think I am short of words to explain Dr. Goswami, and I will not take much time and hand over the platform to him.
Thank you, Dr. for your kind introduction and the chance to give me this discussion with my friends. So today we are going to discuss about a problem of upper GI bleeding, and the problem is how to manage this issue. So this is a common problem all of us anytime in our practice we have to face. I'm just coming with a case few days back in one Saturday at almost 10 p.m. I was just finishing my clinic to come back home. At that moment, one of my colleagues, he gave a call to me. I'm sending one patient with upper GI bleed. Please wait. So this is the problem, because at the last moment, you have to get to treat a patient with upper GI bleed. And it is a life-threatening abdominal emergency. Almost in day-to-day practice, in every hospital, this patient used to come. It is 4 times more common than the lower GI bleeding, and also the overall mortality is almost 6 to 10% all the years what we know. The clinical presentation of the upper GI bleed may be hematemesis, is the vomiting on the blood, or coffee color, may be red. It may be melena, most of the time tarry black colored, and also even it may be a hematochezia where you can get the red blood with the stool. Then again, we have the immediate attention, because we have to clearly evaluate these patients. Also, we have to resuscitate the patient. This evaluation and resuscitation is the key in the management of upper GI bleed. Always immediately you have to think of the patient condition, whether he is hematodynamically stable or he is in shock, whether he will require hospitalization, and where it should be in a routine room or general ward, or he may have to be admitted in a ICU, or we have to check clearly the source of the bleeding coming from upper GI tract or from the lower GI tract. So if it is upper GI tract, mostly it comes as a melena, and 90% case is from upper GI tract. If it is hematochezia, the chance of having upper GI bleeding is only 10%. That's how grossly we can identify. So what is the initial evaluation? This is very important one. Already I have mentioned about it. You have to take the proper history, physical examination, laboratory investigation, whatever you get immediately. And also after putting the nasogastric tube, you give the lavage, and the color of the aspiration will also indicate to have the proper evaluation. The goal of the evaluation is again important, because that's how you can see the severity of the bleeding. Also you can see or identify the source of the bleeding, and finally you can determine the conditions ultimately which will decide your next step of the management. Please remember that initial evaluation is always the key for the decisions regarding the resuscitation, empiric medical therapy, or the diagnostic testing, what you need in this case. So physical examination, always try to identify, judge at least, how much blood he has lost. It is less than 15% where the patient will be having resting tachycardia, nothing else. But if it is more than 15%, there may be orthostatic hypotension, or it may be heavy bleeding. That means almost 40% or more even, the supine hypotension will be there. So risk stratification is again an issue because immediately after the evaluation, you can see what is the risk of this patient, because next step you have to go for the exact management. The clinical picture, the endoscopic picture, and also the laboratory test, the features ultimately will decide the risk stratification. So there are some indications for severe bleeding. At least immediately you can see if the red blood is coming from your nasogastric lavage, if there is tachycardia, and if the hemoglobin level is less than 8 grams, immediately you can judge that the patient has got severe blood loss. Then the next step, we have to identify at any cost what is the source of the bleeding. It is coming from the peptic ulcer in case of upper GI bleed, or it is in the esophageal varices or gastric varices. Because these two conditions are different, although both of them are giving the same presentations of upper GI bleed, the line of treatment will be a difficult and a different one in these cases. Coming to the peptic ulcer bleeding, we should remember that upper GI bleeding, almost 30% is related from the peptic ulcer. 20% cases of peptic ulcer, they experience bleeding from their ulcers. The annual risk factor is 4%, and almost 30% of those bleeding from upper GI tract in the elderly group, it is related to the NSAID intake because of the poly medicine they have to take in the elderly life. The varicose bleeding facts, again, we have got clear picture. Up to 20% of upper GI bleed comes from esophageal or gastric varices. The esophageal or gastric varices may develop in 60% cases of cirrhosis. 30% of these patients will bleed within 2 years of the diagnosis. And the risk of the second bleeding, usually 70% in 2 years. So once somebody has got the bleeding this year, after 2 years, they have the chance to re-bleed in 70% of the cases. And up to 50% of the patient, they usually die during the bleeding from advanced liver disease if it is a varicose related. So by the meantime, our patient reached the clinic, the young university student. He had 3 bouts of hematemesis, 4 bouts of melena. The history shows that he is not alcoholic, he is not diabetic as well, but his pulse is 110 at that particular moment, and blood pressure is 90/60. So always in these cases, you take the history properly, then you go for the examination, physical examination, you look for the vital signs. You see the overall appearance of the person, abdominal examination to rule out any other complications like peritonitis, perforations and all. And also don't forget about the rectal examination, because sometimes you can miss something with the rectum, the bleeding source, maybe something else. The assessment of the patient, most important thing is your pulse, systolic blood pressure, orthostatic drop of the systolic blood pressure, oliguria, cold extremities, and mental status examination. These are very important ones because the line of treatment will depend upon these conditions. Then also don't forget to assess the comorbid condition of the patient in upper GI bleed, because this comorbid condition and ultimately make the patient more susceptible for other problems. For example, the adverse events of anemia, the patient have got a coronary artery disease or pulmonary problem. They may have the problem of anemia, and it can lead to aggravation of the condition. It can predispose to the volume overload if the patient has got the heart failure or the history of kidney disease. Also, it results in the bleeding more and more, and it is difficult to control if the patient is having the coagulation issue, coagulopathy or thrombocytopenia, or the hepatic dysfunction. Also, it can sometimes lead to the aspiration if the patient has got dementia, or for example, he has got hepatic encephalopathy. So this comorbid condition is important because ultimately your management is related with these ones. So ultimately, we have got the adverse prognostic factors. If the age of the patient is more than 60 years, comorbid conditions we have got. If the systolic blood pressure is less than 100, pulse is more than 100, if the stool color is red or maroon, or in the patient we have got at least 3 units of transfusion to stabilize the patient, then you can see from here the systolic blood pressure less than 100, pulse more than 100 with the maroon or red color stool. Your chance of mortality will be almost 20%, and operative intervention is also as high as 50%. So next comes the upper GI endoscopy. So this is a very debatable issue because some people, they say that we should not go for endoscopy immediately. Some people know it is the first priority to go for the endoscopy. So here is the question, when to do it and why to do it, why endoscopy is necessary. Because endoscopy, it allows the accurate identification of the source of the bleeding and the severity of the bleeding. We can see what he has got. It helps to predict the likelihood of the rebleeding. I'll discuss one by one later on why it is important to identify the cause of the rebleeding. And also it helps that ultimately some cases you have to go for endotherapy, and endoscopy will lead you in the direction. There are different ways for endoscopy, and according to the timing, it is urgent, emergent, or it may be an elective one. It is seen that different studies clearly show that the early endoscopy is very good because some of the cases, they have got the shorter hospital stay, and also it can reduce the mortality of the patients in upper GI bleed. Of course, we have got the risk we have to keep in mind because the pulmonary aspiration, there is a chance of the problem with the medications that are used for the sedation. There is a chance of perforation, and also there may be more bleeding if you go for the therapeutic intervention. But still, it is the risk benefit is definitely better one. So you should go for endoscopy. So now, at almost at 12 o'clock at midnight, we had to go for endoscopy because the condition of the boy was not very good. Pulse more than 100 and systolic blood pressure was less than 100. And unfortunately, at that particular moment, my colleagues, assistants, they left the hospital. Somehow, next day, it was the Sunday. So somehow with the the nurse, what I had with me, we decided to go for endoscopy of this patient after resuscitation. So you see the ultimate picture what we got. Here, the duodenum, this is the ulcer, and from the ulcer, it is continuously bleeding. This is the area, continuously bleeding, and blood is coming. So we decided to go for the therapeutic intervention endoscopically because it is difficult to stop with the medicine. So we had the option of adrenaline injection, 1:10,000. We injected this adrenaline solution surrounding the ulcer and tried to ultimately stop the bleeding. Usually here it would have been better option to us is the endoclip, but unfortunately that particular moment I was not having the endoclip with me. But anyway, somehow we managed. You can see here the bleeding was more or less stopped. We put the patient in the ICU for 48 hours observation. After that, probably we had to go for the second relook endoscopy to see. It is not the only case with bleeding like this on endoscopy you can see. This is another case of me. You can see the bleeding from the esophageal varices is the grade 4 varix and continuously it is bleeding. Or sometimes you can get this type of patient where the endoscopy of the esophagus is completely normal, but once you reach the stomach, it is full of the occult blood, the altered blood. So these are the patient's presentation in upper GI bleed, and endoscopy we can assess what he has got. The severity as well as the source of the bleeding can be identified. The source of the bleeding from upper GI tract may be ulcer, varix, malarious tear, erosions, even neoplasm, vascular ectasia, and sometimes you may not find any identified source. So this is the picture I am giving here, and all lots may be there, but most important thing is the ulcer and the varices. This is another pie picture showing different causes in case of upper GI bleed from another study. I am not going in details about it. So coming to the prognosis of the variceal bleed, we should remember that almost 50% mortality is attached with the variceal bleeding. And most of the time, it is the severity of the liver disease that indicates the mortality. In C cirrhosis, very ultimately kill the patient in almost 50% of the cases, whereas in child A cirrhosis, it may be just a 5% mortality. So who are likely to bleed? There is a big question, and the answer is established today. The size of the varices, the appearance of the varices, and also what I mentioned just now, and the severity of the liver disease, ultimately they decide the mortality in this group of patients. If the child C cirrhosis, large varices with red wale sign, there is chance of 65% risk in 1 year of the bleeding. But if it is a child A, small varix, no red wale signs, the 2% risk of bleeding in these cases in 1 year itself. There is a big question about the role of nasogastric tube. So nasogastric tube may be necessary in case of upper GI bleed because the placement of nasogastric tube can be considered. It can show us the prognostic value in some of the cases, and also just before the endoscopy, nasogastric aspiration can clear the whole stomach or esophagus, and the endoscopic visualization may be very nice to see. You can see from this study the nasogastric aspiration color, clear color or even red color. It shows the different picture altogether. The transmission rate, the dying rat or the intervention of surgery, clear picture of the nasogastric aspiration or the red colored continuous aspiration, the mortality is high, surgical intervention is high, and also blood transfusion is definitely more. Similar way, the nasogastric aspiration color, the stool color, both of them also can ultimately identify the chance of mortality in this group. Clear picture, nasogastric aspiration, stool color red or brown, 6.0 mortality, whereas it is red color aspiration and brown, black, or the red color stool, it may be as high as 28.7. So if the patient is cirrhotic, non-cirrhotic, it is not that all cirrhotic will bleed from esophageal varices. You can see from this patient who came to me, an alcoholic for 20 years, he presented with the upper GI bleed. And this is the endoscopic picture. So immediately you can see the bleeding from esophageal varices because it is a grade 4 varice with red signs all along. But coming to this patient, again the cirrhotic, but he is cirrhotic for 4 years, presented with upper GI bleed. We did the endoscopy thinking that he has got bleeding from esophageal varices, but the esophagus is having grade 1, grade 2 varices and very unlikely to bleed from esophageal varices. So when we ultimately started going further, we saw that he has got the big ulcer in the pre-pyloric region, and this is the ulcer where from the bleeding came. So that's why always we have to see individually to identify the source of the bleeding endoscopically. So main principles of the acute management of upper GI bleed, the main goal should be to restore and maintain the hemodynamic stability, to maintain the adequate oxygenation of the person, to control bleeding, and to ultimately prevent the complications from this upper GI bleed. And that's why it is a multidisciplinary care. We have to involve the hepatologists, critical care personnel, everybody to ultimately save the life of the patient. So immediate steps in the management of upper GI bleed, the first thing is the ABC of the resuscitation. You assess the patient properly, resuscitate him immediately. After that, risk stratification is very crucial. Identify the patient for low risk. You get the patient admitted in the general ward or the room, or you can put the patient in high risk group of patient. If it is identified, you put him in the ICU and go for urgent endoscopy. But in case of those patients in the low risk group, you can go for next day routine endoscopy, nothing to hurry. The therapeutic options, what we have got in upper GI bleed. We have got the pharmacotherapy, we have got the endoscopic intervention, surgery, as well as the radiological intervention today. We have got the pharmacological therapy. The basic aim of the pharmacological therapy is to stop active bleeding, to prevent the rebleed of this patient. And we can do it if we can reduce the gastric acidity, and also if you can have the medication to constrict the bleeding vessels. And finally, we have got the molecules with the tranexamic acid, H receptor antagonists, PPIs, or the prostaglandin analogs. Let us discuss about it. But before that, probably we should ask ourselves, do we need any acid suppressions? This is the answer what we have got. If the intragastric pH is less than 5, the pepsin accelerates the clot lysis. That's why more and more bleeding may come up. But if we can maintain the pH more than 6 in the stomach, it will effectively help to platelet aggregations there will be irreversible inactivation of the pepsin, and also there will be optimal maintenance of the hemostasis. So that's why the PPI or H2 receptor is important to maintain the pH at around 6 or over 6. Why PPI is effective? Because it is ultimately seen the frequency of the rebleeding is reduced, the need for surgery is reduced, the need for transfusions are also reduced, and finally the length of the hospital stay also is reduced with PPI. We have got the pantoprazole IV, directly we can give continuous therapy, or we can give the rabeprazole with 6 hourly 20 milligram every 6 hourly, and that ultimately can lead to our desired maintenance of the pH of the intragastric situation at 6 or above. Here this picture clearly shows the use of the PPI versus the ranitidine. With the PPI, we can maintain continuously the pH level at 6 or above. But with the ranitidine, the first day it can maintain the pH, but the next day or next day it goes down like anything. So that's why today it is established that PPI is far effective one than the ranitidine or H2 receptor antagonist. Then there is a big question about the tranexamic acid in use for upper GI bleed. It is an anti-fibrinolytic agent, yes. Theoretically, it has got the advantage, but we do not have any RCT trial to establish its use. So that's why better it is of no help. That's what our opinion. Then for last few years, there is a question about the role of erythromycin. It is a prokinetic agent, yes. And also if you give just before the endoscopic procedure, give erythromycin IV, and it helps the visualization of the endoscopic procedure. Probably due to the prokinetic agent, it can help to empty the stomach immediately, and you can see the endoscopic clear picture. And also there are studies now they are showing that as a whole it reduces the transfusion requirement in upper GI bleed. But whether it drastically reduces the bleeding is not clear till today. There is another words about the H. pylori and upper GI bleed. It is seen that some of the patients, suppose the peptic ulcer bleeding, they have got the positive H. pylori. The consensus today is always treat H. pylori after the control of the initial bleeding, probably after 3 weeks or 4 weeks. And also it is seen that the rebleeding rate after treating H. pylori is quite good, quite less if compared with those patients where the treatment of H. pylori is not done. Almost 28% cases, there is a chance of rebleeding with H. pylori related cases. We have the endoscopic interventions. It reduces the bleeding. It almost stops the active bleeding. The rebleeding risk is reduced. Need for any blood transfusion is reduced. Hospital stay and cost is reduced. And also it prevents the emergency surgery most of the time. This is the endoscopic picture, what we call the Forest classification, where there may be spurting, bleeding, oozing from the ulcer side, the visible vessels, adherent clot, pigment spot, or the clean base ulcers. And this is important because you can see from this picture, the endoscopic picture, if it is a clean base, the re-bleed or the mortality is drastically reduced. If you compare with the active bleeding on endoscopy, the rebleeding rate is very high, as well as the mortality is also high. endoscopic stigmata and the endoscopic intervention, that is another study clearly shows that if the patient has got the endoscopic picture of the active arterial bleed, and you have done the endoscopic intervention, or you have not done any intervention endoscopically, the endoscopic intervention is also here. You can see 90% cases, but if it is with endoscopic intervention, you can get 15 to 30% cases the chance of rebleeding. Similarly, everywhere the intervention by the endoscopy, you can get some good results. So what we have the endoscopic techniques, endoscopic injections, the one channel and as a tamponade effect, volume tamponade effect surrounding the ulcer. We should remember therapy or clip use. So these combinations are better than the individual one. Then you can see this is one of my patients. Here again, the bleeding was coming from the ulcer in the duodenal valve. Here we get the injection given at that particular site, and the next day you can see the picture is completely clean-based ulcer. That's how it can be helpful in bleeding peptic ulcer. This is another patient actually who was coming to us from another hospital, from another town with the upper GI bleed. And you can see the polyp here, and at the top of the polyp, we have got a big ulcer. And endoscopically, we removed that polyp immediately. The bleeding was stopped. And next day, the picture of the relook endoscopy, you can see here the ulcer, removal polypectomy site is clear. We have got the other endoscopic methods with heater probe, bicap, laser therapy, or your argon plasma coagulation. In different cases, we have to use in different way. Of course, there are some specific contact thermal devices which are very popular nowadays endoscopically. It may be multipolar probes, heater probe, or monopolar probes. They're safe, effective, easy to use, and also it is portable. That's why we have got the advantage. Now, these pictures I am showing here, the picture with a ulcer, with a visible adherent clot over the ulcer. Then we have got this one with an ulcer visible vessel, or it is a continuous bleeding ulcer. So these are some important issues because we need the endoscopic intervention in these cases. The controversy is about the adherent clot. So earlier the debate was we should not interfere here, but nowadays we should actually remove the clot from the base of the ulcer. You can expose the base, then you go for the treatment. You can put the clip, or you can go for heater probe, whatever may be necessary one. The clips are definitely very good options for us because so many cases we can use in upper GI bleeding. For example, this is what the animated version, I'm just showing the picture, the clip, you put it and easily you can ultimately stop the bleeding in upper GI bleed, especially from the ulcers or Mallory-Weiss syndrome. Then we have got the use of these clips very effectively in Duluth lesions, Mallory syndrome, or ulcers with the visible vessels. Maybe good. This is one again picture, the slide I got from my friend Manu Tendon from AIG in Duluth lesion. Now coming to the varicose bleed, the similar way we have to resuscitate the patient if the patient has got bleeding from the esophageal or gastric varices. After the resuscitation, we have got the options, the pharmacological options, or we have got the endoscopic options. The pharmacology here, we use the terlipressin, somatostatin, or octreotide. Next thing, we have to go for endoscopic variceal ligation, band ligation, what we call. And in some cases, ultimately, we have to go for tips or shunt therapy, or sometimes temporarily we can use the balloon tamponade. And here we can see that in clinical practice, the band ligation is not a very big issue. In small town also, anybody can do it. So you can see this patient where the patient came with bleeding, and subsequently after the resuscitation, we can see, identify the lower end of the esophagus and the varix. Then we put the band ligation done. Immediately, the chance of bleeding is definitely goes down. And after, this is another picture of this patient. After 7 days, we just checked it whether it is okay or not. So this is another picture with the gastric varix. In the fundus, you can see the big gastric varix. And here also you can put the glue injection and you can stop the bleeding in gastric varix. So there are some emerging endoscopic trends we have got. This, what we have got, the Danish stent. We have got the hemostatic powder spray. We have got the suturing, endoscopic suturing, what we call over the scope clips, and also recently we have got the Doppler probes. So this Danish stent, it is a very thin, affordable stent. If the patient has got severe bleeding from the esophageal varices, if your band ligation is not possible, severe bleeding, in those cases, you can put this stent and ultimately you can stop the bleeding. It is the self-expandable stent, it is removable, and it is a covered stent. Immediately it pushes the esophageal varices against the esophageal wall and bleeding is stopped. This is what ultimately it is done. And after 10 to 14 days, you can remove the stent, and by the meantime, you can treat the patient in other way to stop the bleeding. Then we have the over the scope clip. Nowadays, it is coming up in a big way. Of course, it is a bit costly till now. Probably it will be helpful, or it may low cost ultimately after some time. Also, it is very good for the bleeding upper GI tract. We have got the endoscopic hemo spray. Through the endoscope, through the biopsy channel, you can put this spray. It is a powder which will be sprayed over the bleeding ulcers or erosions, and it will be stuck up over that particular tissue once it's come in contact with the tissue, and bleeding can be immediately stopped, and subsequently you go for the treatment. There are publications clearly showing the advantage of hemospray in upper GI bleed. Then finally, we have got the endoscopic suturing today, which are also probably a good tool for upper GI bleeding, and it is for the future. So what about the rebleeding? Already we discussed about the medical treatment, we discussed about the endoscopic treatment. But again, there is chance of bleeding. That's what we call the rebleeding. And the causes of the rebleeding already we discussed earlier. But the point is, if the chance of rebleeding is there, up to 20% cases, and it usually comes within 48 to 72 hours after the treatment. And the advice is you try for the second time, and probably you can get a success up to 50% of the cases. So factors associated with the rebleeding is this. At the time of the presentation, if the patient was unstable hemodynamically, the hemoglobin is less than 10 gram, if there is active bleeding on endoscopy, and also the ulcer size, if it is bigger from 1 centimeter to 3 centimeter, and the site of the ulcer, the location of the ulcer, if it is the posterior duodenal valve, or if it is a high lesser gastric curvature, so the chance of rebleeding is always high. Then we have got the role for the surgery. Yes, the role is limited now because we have got the better medical management. We have got the so many endoscopic methods, one after another coming up and coming up in a big way, and all of them are more or less more successful ones. Also, we have got the radiology to ultimately help us in stopping the bleeding. So role of surgery is definitely diminished for last few years. But ultimately we have to remember that it is the still most effective and definitive therapy, and also it is the final option what we have got. That's why just like medical treatment, we have got the endoscopic treatment, we have got the endoscopies, but we have to keep our surgical colleague, surgical friend all the time with us, so that at the need of the hour, they can ultimately come up and do miracle to us. So in spite of the medical therapy, in spite of the better endoscopic interventions or radiologic interventions, still the mortality is high in case of upper GI bleed, and it is still 8 to 10% because the aging population, because of the increasing comorbid conditions. That's why the management of upper GI bleed is a team effort. You need the radiologist, of course, you need the surgeon, but you need a gastroenterologist as well as the critical care personnel. We have got the radiology today coming up in upper GI bleed, where angiography is done and finally embolization is also done. These are some of the pictures where you can get the relief of them. I had the chance, an opportunity to be with the Mayo Clinic for a few days. So there I have learned a very new thing, that they have got the bleed team. So one whole 24 hours, a team of doctors, all the bleeding cases, whenever it is coming to the hospital, they are usually controlled by these people. A gastroenterologist is a Topajian, he is my friend, then the surgeon, and also a critical care personnel. 3 of these people, they take up all the GI bleed cases for 24 hours. Every rotation they have got, and ultimately they get the better result. And this is the picture showing a publication where we have got the role of the expertise. If you have got the team effort, like GI bleed team and the general usual treatment group, the rebleed rate, surgery, mortality, length of the stay in the hospital, or the hospital cost, everything may be a different one. That's why the importance of the expertise we should keep in mind. So in case of active bleeding, my friends, this is the end point, the conclusion. You have to go for immediate assessment. Then you stabilize the hemodynamic status of the patient. Then you go to identify the source of the bleeding. Then you try to stop the bleeding It may be medical therapy, it may be endoscopic therapy, surgery, or the radiology, whatever it may be. You treat the underlying cause subsequently, and finally, you try to prevent the recurrence of the bleeding. With this, I conclude my talk. Thank you for your kind attention. Thank you.
Thank you, Doctor.
Thank you, Doctor.
Dr. Goswami, there are one question in the question answer box. Dr. Devajit Guru. Can you see the question, sir?
Question, I can see the question. Yeah. Just a minute. This is a question from Devajit Borua from Aizawl. How to manage the post-EVL ulcer bleed? Yeah, it is a very good question, Dr. Borua, and it is a real problem for everyone in gastroenterology. What happens usually after the EVL is done, second day or third day, or even 7 days or later, there may be bleeding, and usually the sloughed out the area where that particular band was placed, it's sloughed out after 7 days or 6 days, and that's what the bleeding comes. So what we should do, again, a similar way, you admit the patient, assess the patient, and you try to immediately put the patient on your medication. And here the medication will be very good with the PPI. You give an antibiotic, then you put the patient on your terlipressin or octreotide. After that, nowadays you can go for the hemo spray. It is very good to control the post-EVL bleeding. And if it is not available, at least you can go for the glue injection. You spray the glue injection around that particular area through the endoscope, and you can achieve to stop the bleeding. This is what we have got the questions. Any other question they have?
Doctor, Mr. Sakshar has got one question. Somebody has sent.
I have not seen here.
Mr. Sakshar, you have to unmute your audio.
Doctor, like how long can a PPI be prescribed? Like by looking at the safety or how long it can be prescribed?
Yeah, this is a very pertinent question today. First of all, as we are discussing about the upper GI bleed, I have mentioned that initially during the bleeding, we should give the IV injection continuous therapy or even 6 hours, it doesn't matter, with the same result. We used to give for 3 days IV injections of PPI. After that, you can ultimately change it to oral tablets or oral capsule. That is the point in relation to the upper GI bleed. But your concern is about the safety of the PPI. Yes, there are so many issues coming up now. Even with bleeding or without bleeding, people used to take the PPI for long years, even not to speak of months. But if you are asking to a medical personnel, why we use the PPI? First of all, we use the PPI in different conditions. For example, if the patient has got peptic ulcer, for example, we are using the PPI. So when the ulcer will be healed, usually it is healed within 8 weeks and maximum 12 weeks. So 2 to 3 months is the ideal time to heal an ulcer. It may be stomach, it may be the duodenum, whatever it may be. So that's why this is the time we should continue the PPI. Or suppose the patient has got gastroesophageal reflux disease, then also we use PPI to ultimately heal the ulcers or erosions of the esophagus in reflux disease, or to ultimately alleviate the problem, the symptoms of gastroesophageal reflux disease. So there again, according to us, we should continue only for 3 months, three months maximum. After that, we should continue the medicine for GERD on different maintenance dose. It may be alternate day therapy, it may be intermittent therapy, it may be weekend therapy. For 2 days in a week, you take the PPI, after that you stop it. Again, you next day go, next week you go for 2 days in a week therapy. Or sometimes you can use it whenever it is needed, on demand therapy. You can continue like this if there is symptomatic patient, or if there is erosions coming back, or suppose in the ulcer cases, suppose this patient has got bleeding from an ulcer, or without bleeding the patient has got an ulcer. So ulcer healing is the prime aim of the moment. We'll heal the ulcer with PPI. Almost 90% cases you can heal it within 2 to 3 months. After that, patient can ultimately reduce the dose, half the dose he can take, then he can go for alternate day, or 2 days gap he can give, and after that he can take one tablet. Having said all these things, if if suppose a person is taking for a long time, long years even PPI, so till today the data what we have got, there is a concern of some kidney injury, or suppose there is higher chance of fracture of the femur, there is higher chance of infection of the GI tract. So all these issues are discussed in different international forums. But it is seen that these studies where it is described is a very small studies, and these are not the prospective studies. So that's why now it is established that we should be worried, but not too much worried about the side effects. Till today, PPI is a safe drug. All these reports what are coming, it is a coincidence, some cases. It is not the cause of the disease. So there is no causal correlation. It is just the incidence, coincidence what we can say. So we should be cautious, but we should not be very much worried about the side effects.
Doctor, there is one more question in the question box.
Just a minute.
Dr. Kavyashi Sonomal.
Yeah, what is the dose of varicose? Yeah, it is also a good question. First of all, this terlipressin should be given 2 milligram every 6 hours. That is the standard of care therapy. Terlipressin is the safest drug, number 1, and you can say it is very important drug for the patient with variceal bleed. That's why my advice is all the patients with cirrhosis, if he is staying out of the reach of any small town, or suppose immediately he cannot come back to a hospital in any time of bleeding, they should keep this injection, at least 1 or 2 injections with him at home. And immediately, if there is a bleeding, if the patient is a non-cirrhotic one, he should take the injection IV directly with some local doctor from that particular area, and it should be immediately shifted to a hospital where we have got the ICU provision. So terlipressin is a good drug for the patients with variceal bleed.
I think
there are no more questions, doctor.
Yeah.
Yeah. So, doctor, we thank you very much for sparing a valuable time. and giving a lot of insights into upper GI bleeding. Thank you so much, sir. And we thank all the participants also for the day. Thank you, doctor. Please take care.
Thank you.
Thank you, sir. Thank you so much.
Thank you, Doctor.
Thank you, sir.